Right. All right. All right. So, can everybody hear me? Okay. All right. So, I'll go ahead and get started here as people kind of come in. So we have actually 4 different trials in renal denervation, and spiral hypertension is actually divided into 2 trials, the on and the off. And so we're actively enrolling in all 4 studies. So if you have the criteria get a little bit fuzzy sometimes because there's slight differences, but I think if you have a patient who is not tolerating medications or we're kind of close to the resistant or difficult to manage, or they're interested in a study such as this, and just feel free to send a message to myself, Rose or Karina or any of our research people, and we'll be happy to kind of look through it and determine if the patient's a candidate. If you could just introduce the subject to them, and that would help us out. So without further ado, I'll go ahead and talk about renal denervation. It's a subject, it's something that is a little bit out of the mainstream of, especially as interventional cardiologists, what you might envision one doing in terms of taking care of hypertension in and of itself. So these are my disclosures. So it's really been an up and down roller coaster for the area of renal denervation, and I'm not sure how many people have are familiar with the concept or have kept update to it. But in 2013, when the field was quite robust, it was probably the second most discussed topic at TCT, and then unfortunately it sort of fell to the center of the earth with Simplicity HTN-3, which basically stopped the entire field dead in its tracks. But with the perseverance of some companies and people who still believe in the concept, the field has regained a little bit more inertia again. So it's I think the last time Rob and I presented this was back in 2014 when the trial, the HTN-3 trial came out, and so I think we have some new and exciting news to present here today. So I just kind of browsing through my phone, and this came up a few days ago. Will renal denervation for hypertension rise again from the ashes like a phoenix? I think that's a very good question, and that's a question that we're hoping to answer with all the studies that we're doing right now. Well, hypertension is the most common diagnosis you'll make. You can just pretty much put that on every single patient's problem list, and that's just something that we assume and we take care of. And I don't have to preaching to the choir in terms of what the consequences of poorly managed hypertension is, and we take it for granted that we're doing a good job of taking care of hypertension in general, but I think there's some realisms that we probably don't quite realize. So hypertension remains the leading global risk factor for death. In fact, it's accountable for about 11 million deaths per year worldwide. And it's by far the greatest risk factor beyond any of the other risk factors listed here. And some very smart epidemiologists kind of forecast this out to 2040 and predicts that it will remain a huge problem even at that time. So in our medical careers, this is a problem that's not going to go away. So I think based on many trials that we've assumed that we've taken for granted in the past, we know that reduction in systolic blood pressure, or the previous parameter of systolic blood pressure, office systolic blood pressure, will result in improved outcomes, cardiovascular outcomes. And that's why we take care of patients and emphasize the importance of blood pressure management. And the SPRINT trial sort of reinforced that with a more aggressive approach, resulting in more significant cardiovascular risk reduction, and up to 25% just by a difference of 20 millimeters of mercury. And I think at one time I decided just to look at all the antihypertensives that were available. This is a few years old, but I counted like in the 280 range. And it's surprising how many we actually use in our daily practice. So when I go to these hypertension meetings, cardiologists are not the hypertension experts. In fact, they made fun of me because you bring your beta blockers, your ACE inhibitors, and you think you know how to take care of hypertension. So from that point on, it pretty much did not identify who I was. It's really the nephrologists and some of the internists that were really quite good at taking care of this. So we know that when people take their medications, they actually work. But the problem is not, they don't do a very good job of it. So if you have good adherence, that you take 80 to 100% of prescribed medications, you're going to do very well. If you take 50 to 80% of your medications, your risk is going to increase significantly. And if you have poor adherence, and that's not taking any, but just less than 50% of your medications, your risk will increase substantially. And that's sort of the foundation for why I think renal denervation is going to be a adjunctive tool here. So why is it that our patients have such difficulty in taking medications? Well, nowadays I'm actually looking at the medication list a little more carefully. And if you're in a clinic and you have 2 minutes to see the patient, you're flipping through their sheets of medications. I think sometimes you just have to wonder, how do they do that? I mean, they spend pretty much their whole day taking medications, and doctors are really good at adding medications, but they're horrible at subtracting medications. So it just keeps on getting added, and patients become frustrated. And there's a publicity about, blood pressure medications being bad for you, or statins. And of course, they have the resource of Google, and they will go online and pretty much look for reasons why they can come off the medications. And so we think we're doing a pretty good job, but we're really not. So I think despite the prevalence of hypertension being relatively steady, our ability to control the blood pressure is still less than 50% in general. And so this is a nice study, which kind of akin to a lot of times when we ask ourselves, how many years would you give up if you could eat anything you want? And we probably said about 2 years, 3 years, 4 years. But they did ask the question, how many of you would give up something to not take one more medication for blood pressure? And actually, 30% would sacrifice some lifespan to not take one single medication. So I think this point we underemphasize a little bit. I mean, we underappreciate a little bit as we began to recruit for some of our patients in terms of how powerful that desire is for finding an alternative. So the 2017 ACC-AHA guidelines also, I think, kind of established what we typically practice, but did upset a lot of what the other people were doing. It essentially said, well, pre-hypertension is sort of like hypertension. It's sort of like saying having a little coronary disease versus a lot of coronary disease. So we're just going to label it all hypertension. So they changed rules. JNC7 was around for a decade. JNC8 was pretty much worthless, but the ACC-AHA guidelines have stuck around at least for most of us. And so what does that do? Well, with JNC7, you had about 70 million hypertensives in the country, which is about a prevalence of 32%. If you change the guidelines for everybody, then it goes up to 46%, which is essentially half the people in this country have hypertension. The rate of control was reasonable at 50, but if you change the guidelines, then it decreases to 39%. If you walk past the primary care clinics, you'll see that they have this board of shame of how they're doing in terms of blood pressure control, hemoglobin A1C, smoking, and they get paid based on these criteria. So they weren't very happy when we changed this, and also they didn't necessarily believe that that was the criteria that their patients, we see patients that are sick and have cardiovascular disease. They see patients who are, 35 years old, have no other risk factors, and they're not really happy about adhering to this level of control. But it does change. So there's a lot of different societies, and they vary between 130. We adhere to mostly 130 over 80, but they still stick to the 140 over 90. And so, in our lifetime, hypertension management has really been all about medications, because we've really been fortunate to have the luxury of all the different types of medication, many of which are actually targeted towards the sympathetic system. But sympathectomy actually goes back a long ways, back when there were no medications available for management of some of the very difficult patients. And that concept has risen again because of advancements in technology. And essentially, initially for patients who had resistant hypertension, that didn't really respond to these medications. We know that the central sympathetic drive is elevated in patients who have hypertension of different sorts. This has been proven in animal models. And back in the day when they did sympathectomy, interesting enough, it kind of reflects to how our experience at this time is that it was a horrible procedure, really reserved for the very difficult to manage. I mean, it's if you look at the highlights, retropleural, retroperitoneal, transfer, diaphragmatic, it worked about half the time, but it didn't work for everybody, even though they physically severed the nerves. But they decided, well, that's just a horrible thing to do and not practical. So, but that concept, you know, kind of was in the background for a long time, and now has arisen because now we have different ways of accessing that. We know there's a lot of different communications between the kidneys and the central nervous system. As a cardiologist, I'm naturally led to believe that the heart is the center of the universe, and it's the most important organ in the body. The hematologists tell me that it's only used to pump, you know, chemotherapeutic agents. But so I think, but in terms of hypertension, it's really the kidneys that are the most responsible, because if you look at all the drugs that we use, a lot of them target that particular organ, and so the nephrologists are the people who actually get referred the people with resistant hypertension, the patients with this. So I think in animal models, I think we were a little deceived at the beginning because we thought that the nerves, the sympathetic nerves, ran very close to the outer rims of the renal artery itself. So based on that concept, technology was developed. Animal models were developed to show that different types of energy could effectively reach those areas and do denervation with high effectiveness. And so the first of the devices was developed, the Simplicity catheter, in the mid to late 2000s. It's a unipolar deflectable tip device that delivered radio frequency energy at 5 to 8 watts. And so development of that particular technology allowed us a way to access the sympathetic nerves in a way that we weren't able to before. And so this initiated a whole series of the Simplicity trial, initially 1 and 2. And so these trials were, you know, initially published and added in the 2009 to 2011 range. And these were non-randomized trials in Europe and Australia, initially starting with a smaller cohort and then expanded. The exclusion criteria, which remains fairly similar even to this day, you know, greater than 18 years old. Now, the patients that were targeted at that time were resistant patients, and there's still a relatively strict definition of what that entails. But typically, patients with systolic blood pressure greater than 160 and greater than 3 antihypertensive agents at maximal doses, so 50 milligrams of hydrochlorothiazide, you know, 100 to 200 of metoprolol, so very high doses, including one diuretic. And the exclusion criteria has remained essentially the same for most of these studies: reasonable renal function, non-type 1 diabetic, and even some controlled, not poorly controlled type 2s, no secondary causes, and no evidence of renal artery stenosis or fibromuscular dysplasia. And so the Simplicity one was sort of eye-opening. And so, yeah, I mean, this is sort of the 3-year data, but you get an initial improvement of 20/10, which is outstanding. But a 1-point treatment then led to progressively improved blood pressure, which is something that we couldn't really understand. But since it was, you know, going the direction we wanted, I think people enjoy those results. And so, but you know, 30/16, if you can do one thing and decrease your patient's blood pressure by 30/16, you know, that would be almost miraculous. So this then led to the Hypertension 2 trial, which was randomized, but not blinded. So again, this trial demonstrated very, very similar results. And so the field started getting really exciting, and a lot of investments and different technology into this area began to develop. So real world, so it moves into the real. So this became CE marked in Europe, and you can use it, and it was being reimbursed based on some of these studies. Registry started, of course, not in the United States quite yet, but real world data sort of supported what was seen in the trials. So, you know, this is unbelievable results, and we were all excited, and all these different devices, you know, began to develop. St. Jude developed their own devices. But as I click through this, just kind of look at how similar all these numbers are. So, you know, again, 30/10 13, 14 with the Paradise device. I'm going to go back one. This device had 8 patients and was approved based on just those 8 patients. It had a drop of 42 millimeters systolic. If you had that kind of result, you would be worried about hypotension or orthostatic hypotension, in fact, doing too much. But this was approved based purely on this one small study and on top of the other studies that were already in place. So this field kind of took off. I don't know, I don't think Rob's here, but Rob is still very involved in the preclinical aspect of many of these studies. And I think we counted at one point that there were 90 companies doing something of this nature. A lot of money was being invested and a lot of excitement in the field. Then we got Simplicity HTN-3, which is a trial in the United States that was required to really get this approved here. It was a much larger study, 530 patients. I think the main difference is that we shifted over to ambulatory blood pressure, which over time has been proven to be even to this day, I think it's probably widely underutilized. In fact, this is what I use to really diagnose hypertension for most of my patients these days. I don't even look much at the office blood pressures anymore, but I do, okay, because I have to, but because the nurse will come up to me and say, hey, his blood pressure is 200. So yeah, you know, but so the main difference is ambulatory blood pressure became in play, and then the more important part is the sham double-blinded approach. So basically, the patient goes through the screening process, and if they're randomized, they're basically, there's probably complete sensory deprivation for the patient, so they have no idea what's going on. I have to believe these patients have horribly high sympathetic drives because it takes like 5 to 10, I mean, every single one of these patients takes like 5 to 10 of Versed and 250 to 550 of fentanyl to get them to stop talking to me. So I mean, with just a little bit of that, I would be under the table. So there's something about these patients that are unusual. So I think ABPM was felt to be a much better predictor of blood pressure control in general. And I'm not sure how many people in here actually use it on a, it's not very wide. We have like 2 or 3 units in the hospital. So it's something that's certainly not available in the outreach clinics. And it's a very difficult thing for patients there to get access to. But, you know, I think office blood pressures, like hospital blood pressures, I think are not very, not nearly as useful for long-term management of these patients. So it was incorporated. Now, all the previous trials using medications and devices have all been based on office blood pressure, so they can't discount that variable. But if you look at ambulatory blood pressures, they're predictive no matter what your office blood pressure is. So if your office blood pressure is 140 and the ambulatory is higher, it's predictive of a worse outcome. And also, in other studies have shown that it's divided into 24-hour daytime and nighttime, and all those components are more predictive than simply clinic blood pressures at every single blood pressure range. So I think Simplicity HTN-3 was considered to be a victory lap for Medtronic. There's no Medtronic people here. So I think it was afterthought that it would not be approved. So I think all the other companies were designing their trials to figure out how to figure out how to redesign their trials so they can incorporate a treatment that's a standard of care, because everybody, it's sort of like the ASD talk last week. It's hard to enroll because it's available and people can get access to it. So if this is available, how are the other trials going to complete enrollment? So that was a mindset going into it. Well, I think show me the money or bring the data. You have to, that's why we do trials, is to see if things that appear obvious are true. I received this letter January of 2014. We're disappointed that the clinical trial failed to meet its primary efficacy endpoint. That was a very depressing day. And so you can just hear, it's the glass shatter, all across the country. So this is presented at ACC of that year and published in New England Journal. So what it showed is that there was an improvement in blood pressure control. Not as impressive as suggested by the previous studies, but that it was equivalent to what the sham arm was showing. So there was no statistically significant difference between the two arms. So this basically, you know, it had reverberations throughout not only the United States and all the people who were looking at, who were involved in the field, but also, you know, had reverberations to Europe, where they began to not reimburse, ultimately not reimburse for the procedure based on this study. Oh, sorry. Let's see. So why did it fail? Well, you know, the technique just doesn't work. We were wrong, and this, you know, statistical power wasn't sufficient. The renal, this one kind of eats at me the most, because the European doctors were saying, well, the U.S. doctors just don't know how to do the procedure. And I mean, I think to their defense, they, you know, a lot of operators only did 1 or 2 cases. So if you did 1 TAVR and started going out and doing TAVR, you're probably not going to be as good. And so the European operators certainly had much more experience. The patients were not stabilized medically. They were overtreated. We picked the wrong patients. Essential hypertension patient, I mean, the resistant hypertension patient was too far along to be affected by this technology, or other factors that we hadn't identified. So first of all, you know, it's sort of a deflectable tip, and you have to try to treat 4 different quadrants around the renal artery. So especially for the interventional cardiologists here, if you could only do a coronary angiogram in a single view, you probably wouldn't be a very good coronary, you wouldn't be a very good interventionalist. So that's what we were trying to do here, is to try to treat this artery circumferentially with a 2-dimensional imaging. So that was a thought that we weren't, you know, doing a good enough job of that. Also, we failed to realize all the preclinical studies were looking at animal models that were normotensive. So it's been shown that in patients that are hypertensive, that they perhaps have a more robust sympathetic network that extended much further out than what we initially imagined. And so, you know, so our view of the renal nerve distribution has changed based on cadaveric, you know, studies that at the ostium or in the proximal main portion of the vessel, the nerves were probably further away from the vessel itself, and it began to congregate as it reached the kidney itself. And that's an area that we were trying to avoid treating, because we wanted to minimize any dangers to the patient, or cause perforations in the smaller vessels. And so in cadaveric models, this plays out to be the case. As you can see, the renal, the sympathetic system does tend to kind of coalesce around the major branches, and as it continues to divide. And also they did, you know, they slice and dice the HTN-3 trial as many ways as they can to find maybe some theme of why it didn't work. They looked at gender, you know, how hypertensive you were, you know, ethnicity, systolic combined. And what they found is that, you know, the more you treated the patient, the more aggressively you treated the patient, the better the outcome and the more blood pressure, you know, improvement you did. So because, and I'll show you on the slide, there's very few complications with this. So you always wonder if we push the boundaries of risk and benefit enough in this particular trial. Because for HTN-3, we were actually instructed to be conservative because it was never imagined that we could fail. So they said, well, you know, only treat these couple areas, don't, you know, go too far in. And so I think certainly this point was well made and formed the foundation of many of the devices that are being developed. And so, you know, so what happened also is that the patients went back to their doctor, and their doctor started changing all the medications. And when you do that, you really dilute the possible effect of the treatment itself. And so this is the slide I showed before, and so it kind of really, a lot of companies went away, and I think there's still some remaining, but I think it's really going to be these 2 devices that are going to determine the fate of, I think, you know, neuromodulation and sympathetic manipulation. What happens to these 2 devices will probably dictate how the other devices are viewed. And so we learned that we need better technology, something that we don't have to guess as to where we're treating. And we have better preclinical science to support that. We need reproducible procedures, devices that will allow it not to be operator dependent. We have to have consistency. I think we still have some issues with how to determine the treatment effect, but we also have picked better patients. The people in Europe persisted, and I think the French, they don't believe quite as much in a blind, like a randomized study or a blinded randomized study, or especially with the sham. But I think in the United States, because of HTN3, there's no way that this device will be approved without that component. But they persisted, and they found that there's still benefits. So, so the companies persisted. So Medtronic, which had a lot of device, came up with the spiral device. Actually, before HTN3, this device was developed, and we were actually quite excited to be able to get our hands on it, but it got sort of shelved for a little while. So it's a spiral device with 4 different electrodes that will kind of wrap itself and form, kind of cover all 4 quadrants of the renal artery. And it has more flexibility in terms of the vessel size. It can treat up to 3 to 8. So allows us to enter it into the main branches and even accessory renal arteries if we need to. The 6 French catheter compatible. So with these type of devices, we are treating as many of the major branches as possible now. As you can see, this is one of the patients we did, and I think he's already unblinded, so I'm not giving anything away. So this is, so it's very flexible, and it's able to reach many of the different arteries. It's also, unlike the previous device, which is sort of free floating, this is advanced over a wire. And so you can see that it does a much better job of covering all the different quadrants, which is necessary. Now, this device will ablate, I think, by preclinical evaluations, probably 2 to 3 millimeters out from the renal artery. So that's going to be a point that comes up as well as we discuss different devices. So we're being more aggressive. We're treating closer to the ostium, certainly the main artery, and even the branches. And we've shown in animal models that decreases the renal norepinephrine levels. And so so patient selection. Now, I think back in the HTN3 days, if you said we should treat anybody other than resistant hypertensive patients, they would have said, you're crazy, because why would you take a patient that's being well treated with amlodipine 5 milligrams and subject them to anything else? But after the failure of HTN3, they began to realize maybe we were targeting, and these are very renowned hypertensive experts who have been in the field and not interventionalists, people who are treating hypertensive patients in general, that finally felt that we should test that population out because it has the least number of confounding variables, and you can scientifically do a better job. So spiral off-med was developed, and I won't go through the criteria too much. Again, it's a randomized sham control, double-blind randomized sham control trial that looks at a 3-month endpoint. And these are the, I think, inclusion, exclusion criteria. I won't go through that too much. Again, the different trials have slightly different blood pressure requirements. So, if you have a patient that may be eligible for any of these trials, just let us know. But they typically have to be hypertensive, either 150 for this particular trial. They have to have an office blood pressure greater than 150, diastolic hypertension too, and also elevated 24-hour ambulatory blood pressure. Again, the exclusion criteria are very similar. And then the on-med was also developed, which looked at not the resistant patients, but patients who are on 1, 2, or 3 antihypertensive meds. Now, this is good in the sense that there's some overlap between the 2 studies. So we could, depending on, the patients have a lot more options in terms of what they're eligible for. And again, they have to be on 1, 2, or 3 medications of one of these variety, at least at the 50 percentile of maximal doses. And so this study was published in 2017 and kind of reignited the field. This is the off-med. And so these are the patients who are either they're essentially medication naive. So if they were on a medication, they were taken off of it, which seems like a very something, that's something that we typically wouldn't do, but for a period of 3 months, they felt it was safe. So they took them off of it, and so they didn't have to deal with the confounding factor of medications. And so what they found is that there was a significant difference at 3 months in terms of both office blood pressure as well as 24 ambulatory blood pressure monitor. Now, it's not the 42 millimeters that you see in some of these studies or the 30 that you saw at most. And then you might say, well, 5, that's great. 5 to 10, that doesn't seem like that much. But if you realize most of the drugs that you use are approved based on improvements of 4 to 8 millimeters of mercury, and that's what showed effectiveness in terms of long-term outcome. This is actually quite promising. And so you can see that it has an effect throughout the entire day in regards to the ambulatory blood pressure monitor versus a sham. And so incredible thing is, I think people worry about, the downsides. You're treating the patients with an invasive procedure rather than medications, which they might have been well controlled on. But the surprising thing is, with all of these studies, even dating back to all the previous studies before HTN-3, these procedures are actually extremely safe. Now, it's hard to believe that there's zeros for everything, but as far as in terms of procedure-related complications or renal artery stenosis, there is really very good safety profile. Now, what's interesting here is that you see that even though we look at the averages, that there are people in both categories who respond to sham and to renal denervation. The majority of the average for the renal denervation patients are better. But this is one of our challenges, is to identify who are going to be the super responders. There are patients who come off of all medication and feel great, and that's sort of, what they come in hoping for. They want to come in, get a treatment, and never have to take a medication again. I'm sure that's the same thing with TAVRs, CTOs. They want that one treatment and never have to worry about this again. So, but this is our challenge. It's to identify who the super responders are. So the OnMed was published last year. This is the patients on 1, 2, or 3 medications. Again, very promising and similar results, where you even more so in this patient population with ambulatory blood pressure monitor in the 9 millimeter range, and it was statistically significant versus a sham in most of these parameters. And again, similar findings to the off-med trial. Now, what's interesting is, these patients came in. They had multiple follow-up visits. They were drug tested, but even under those conditions, their adherence rate was only about 60%. So, which means that, this might be as good as it gets. If you give your patients, medication, you can probably a blood pressure medication. You assume that they'll take it 60% of the time. I think I was at a conference in Europe, and the German interventional cardiologist says, yeah, just treat them all in the United States because, they're not taking their medications and they're all going to eat at McDonald's anyway. So why bother, So I don't think we're quite as desperate as that, but I think this does raise the issue that, our patients aren't taking the medications like we think they are, even under very controlled conditions. What's also interesting is this, is that even with a 0.1 time treatment, you're starting to see, gradual decline in the blood pressure over time. I think if you don't learn from history, you'll end up repeating it. So we have to be really cautious and see what the pivotal trials bring us. And so with these 2 trials, it really, brought renewed enthusiasm into what we potentially could do, not as a solo treatment, but maybe as an adjunctive treatment. So now we're involved in the pivotal trials for both the on and off medication. So if you have any patients that may fit those criteria, please let us know. So I'm going to shift gears and go over to the other system that we work with, the ultrasound-based system, the ReCore. So it's a balloon ultrasound-based system. As it comes up here. So it's a balloon that's size anywhere from 4.2 to 8 millimeters. And smaller balloons are being developed to reach the branch vessels or accessory vessels. And renal arteries are never that easy and pretty, So what it does is the inner part of the balloon is cooled so that it protects the inner architecture of the vessel. And so as the ultrasound is emitting, it will heat up the areas from the apophysia out. And the difference between this device and the radio frequency is that it will ablate up to 6 millimeters. So it's a much greater depth of treatment. And that's perhaps why not as many treatments are required. So I don't know if this played already, but so the balloon goes in and it's, so we inflate. It's a very, it's a very compliant balloon. So there's very little trauma to the artery. With this study, we're doing CT imaging ahead of time. So the imaging section has really been helpful in terms of, doing the measurement of the vessels. So we can determine what size devices we need ahead of time. And then the anatomy and the difficulty and the different views. Whereas the simplicity study doesn't require imaging ahead of time. So I think this has already been shown before, so I will go. So this is a study that we were very involved in. Again, there's 2 arms called the solo and the trio. Again, under the same principles, one looking at medication naive or patients that can be taken off medications. Now, the trio cohort does look for more resistant patients on 3 medications, and they're switched over to a single fixed pill. The interesting thing is we lost a lot of patients with a single fixed pill because they did a better job of taking the medication. So when they came back to us, they were normotensive. And so that also goes to show how compliance can really help these patients. And so I won't go through this too much for the sake of time. Again, it's a double-blind, sham-controlled study. And we published the results last year. And again, it demonstrated the primary FSCAI endpoint was daytime ambulatory systolic blood pressure at 2 months. So it demonstrated a statistically significant difference in per protocol, which of the patients that weren't actually treated actually demonstrated even more substantial difference. Again, this waterfall plot shows that, again, there's a varied response in different patients. Some patients will respond in both arms, but the majority, there's obviously a greater number of patients who responded in the treatment arm. But it's our task to figure out, who will respond to this particular treatment. And we went out to the 6-month, was just published this year in Circulation. So after the patients reach the 2-month period, then their doctors are able to manipulate the medication. And this is where we fear that some of the benefits may get diluted, just like with HTN3. And we did have suggestions of how they can go about escalating the medical treatment, but they're obviously free to do what they want because we're not in charge of their medication adjustments. And what we found at 6 months is that the medication burden for the renal denervation patients were much less than the patients who underwent did not have the procedure itself. In fact, a reasonable number of patients actually didn't require any medications at 6 months. And that and some of the components of what we're measuring was sustained after that period of time. So although this is I don't think this is necessarily a proof of efficacy trial, but it shows that the effects can be maintained even to 6 months and beyond. I'll skip this one. Again, the safety endpoints at 6 months were, extremely low. I think there was one patient who had renal artery stenosis, but that was because they had some unidentified atherosclerosis beforehand, and a few patients with transient orthostatic hypotension. So the conclusions from this is what I suggested is that it looks like the effects were maintained even out to 6 months, in that this would form the foundation of a more pivotal trial, which is what we're involved in. So right now we are involved in 4 different trials. We're involved in spiral, HTN on and off medication. We completed the HTN solo trial, which we were the top enroller in the world, and through the efforts of all the people that are here. And now we're, at the forefront again with Radiance 2, and we're still enrolling for Radiance Trio, so which have become more difficult for us to actually acquire these patients, contrary to what we initially thought. So on the foundation of these 3 medications, I think that forms a good basis for us to go forward. We're optimistic, but obviously very cautious based on our previous experiences. What we also learned is that, initially we thought it was going to be harder to randomize patients, enroll patients in the solo trial because doctors will be resistant to the concept of a procedure replacing a single medication. So we had difficulty engaging these patients or the doctors initially. But then we decided a different approach, which is to do Facebook ads. And because of, we recognize how much medications, patients dislike medications more than we think they did. And so the patients had a direct connection to us. So through this process, which Rose has, been integral in and developed, and through her efforts has been adopted by Radiance and ultimately by Spiral as well, because they saw the success with what was happening. I think over a couple-year period, we got 8 to 10 million hits overall from Facebook for the trials here. It took the Europeans a little longer to accept that strategy, but ultimately they did ultimately agree. But so 500,000, a lot of screening process, so the funnel is very very narrow at the bottom, led to 15 randomized patients. But I think without that, we would have not had that success. So I think the question is, which technology is better? I think the people who have the device available in Europe did actually sort of a head-to-head trial between the different devices, and they looked at the Spiral device if you only treat the main artery, if you went into the branch vessels, and if you use ultrasound. And these were resistant hypertensive patients. And what they found is the rating's a little small, but it seemed like that ultrasound perhaps had some advantages, but I think if there's no statistical difference if you were more aggressive with the Spiral device, because you're getting into the main artery where the vessels are closer to the vessel wall, and so you can better access. So I think ultimately both of these devices are going to be useful and effective depending on the anatomy of the patient, and sometimes the balloons won't be able to access certain areas and the other device, or at some time in the future you may be able to combine these devices for treatment. So in summary, I think hypertension is a significant public health issue, and we know that effective control leads to better outcomes. I think we underestimate the ability of our patients to take these medications, and I think the results of these 3 trials does create renewed optimism for the field of renal denervation, and that we don't look at it as a single treatment, but more of an adjunctive treatment to medications. And that's what we emphasize to the patients. We don't tell them, if you come in and get the procedure, you're never going to have to take medication again. I think that would be the false way to advertise the studies. But we tell them that this is our bottom line is to get your blood pressure under control, whether it's with medications or devices. But we do have newer technology for patients. And I think we still have to learn a lot because, unlike when you put a stent in, you can see that the lumen is open, or if you put in a valve, you can see that the gradient has gone down. We really have no effective way of measuring what we actually did. Other than the surrogate of blood pressure, which is less than desirable. So I think a lot of people are working on markers, maybe some blood sampling that we can do to show that we made a sort of effective immediate change in some of these patients. So I think that will be the holy grail of this particular area. And we don't know exactly what the mechanism is. Is it afferent, efferent nerves, neurohumoral, or is it instant or gradual with the best technology? So these are questions that we're hoping to answer through the pivotal studies and beyond, the pivotal studies are looking at gathering enough data so that this technology can be approved. So I think there's some progress because like the Barrelstem Neo trial, which had its very difficult time. This is a device that it's sort of like a pacemaker for the carotid body. It was, it was very large and difficult, and sort of like the sympathectomies of old that you couldn't imagine doing, but they miniaturized this device and made it better, and it's now indicated for some class 3 heart failure patients. So I think we're getting some traction in this particular area. And so, like as I said here, we're involved in all these studies. If you have any questions about enrollment, about the trial itself, and how you can contribute, please let us know. And so there are a lot of people to thank, people who participated in this endeavor, or people who will be or are. And so people who struggle through the HTN3 with us, Holly McDonald, the imaging sections, and the foundation here are certainly part of all this. And so I hope that in the next couple of years that we'll be going in the right direction in this device. At this point, there's no other centers in Minnesota doing this. I think there's doing any of these studies. And I think there's nobody in the Midwest doing radiance. There's only maybe 2, I don't know, I checked, but I think there's only 2 centers doing both of these trials. So I think, we'll have to see how it plays out. But that's sort of the exciting reason why we work here, because we have access to technologies and we can advance the field and do things that are different from many other organizations. So I hope that we can bring this technology to its fruition and allow it to be part of our practice in some way. So with that, I'll take questions or end the discussion.
Ceiling mics, which eventually will pick up the room conversation for the people joining us remotely. So if you can repeat the questions, then
sure.
People will be able to
yeah, sure.
We're online. Thank you.
Mario.
In my old university, there was this guy who worked on hypertension, essential hypertension, trying to figure out what that actually is.
Right.
And I think, I'm not sure.
Did you get the answer?
Mm-hmm.
Did you figure it out?
No, I don't think they did. But they were looking at like gene bonuses and wrote the nature on it. So I don't know how it developed, but in all of this, because you mentioned these people that stay on the table, you can't sedate them and all of that, there seems to be obviously some sort of potentiality in it that determines why some people have this and others don't. Is there any research going along with this instead of just looking at the expensive devices to figure out maybe such as said these markers or even genetically?
No, I undoubtedly, I remember the first true hypertension meeting I went to. I sat in the back, and it was all nephrologists. I mean, people who, if you asked them about a trial from the 1950s, they would be able to tell you exactly like how many patients were enrolled, all the specifics of the papers that were published. So these were very, and they never believed, at the beginning, they never believed that something like this was reasonable, and because it minimized the complexity of the disease. And so I think there are a lot of, if you look at, just like with any other field, you're getting bombarded with journals, but a lot of them are basic science looking at hypertension and, molecular basis of hypertension. So I think that's why this was so frustrating is that, I think in the back, I think the nephrologist was out front saying, like as I was mentioned before, these damn cardiologists, now they have a procedure and they want to be part of hypertension. So I just sat in the back and kept my mouth shut, but like you said, to be part of anything, you really have to speak the same language and understand that, you can't just be somebody who throws in valves. You have to understand physiology of aortic stenosis or CTOs and coronary physiology. You can't just simply, be there to be and that's why I think this has been, interventional cardiologists or cardiologists in general have been working with because we not only do the procedures, but we also have an interest in taking care of the procedure of the patient. And so, many of us, like, I went through this training and paid my $2,000 for board certification for hypertension, and the HTN3 came out. I said, oh, great, But then I think, but the whole process was very educational, meaning I learned how complex the whole field was. So I guess a long answer to your question is yes, I think there's a lot of research being done, and The journals are very rarely talking about renal denervation. Hypertension journals are talking about many other things. Yes, John.
Well, I might have missed it, but what about the importance of the accessory arteries, the physical size of the arteries, number, and how would you place that relative to being the body of the renal artery?
Yeah, so I think the accessories are important because I think the data would suggest that you really need comprehensive denervation to have an effect. And if you have larger, and so we're going after the accessory renal arteries at this time of reasonable size, and they remain exclusion criteria for some of these patients that can't be treated. So like with the balloon-based technology, if we can't, if it's greater than a certain size and a balloon doesn't fit in there, then they're excluded from the trial because we don't feel like we can offer that service. But with the Simplicity catheter, we can actually access vessels down to 3 millimeters, so we can treat the renal arteries a little bit easier, the arteries that are smaller. So I think Rob has demonstrated, he's very interested in this area as well, and so I think we realize that the accessories are very important. Nick.
So with all of these different trials that you're currently running, who should we refer? I mean, there's no way I'm going to remember all 4 of these.
Right. So I mean, I'll tell you.
Who should we be referring to?
I mean, I have to look at 180, 175. So so you just, if you have a patient that you have told that may have an interest in this, and you've mentioned the trial to them, all you have to do is, I think most of us are Epic savvy enough where you can just send a link to us and say, Yale, patient might be interested. Here you go. And so, Rose, Karina, and I, and the others will screen the patient and look at all the eligibility. We'll get back to you and then communicate with the patient if they're expecting a call. So
Is there a thumbnail that we can think about of what type of patient? I mean, is it anyone with hypertension?
Well, I think you don't want to, we don't want to upset a lot of people by, like if you have a patient. So first of all, most of the patients that we see are coming in because they've had an MI or a stroke or something. So there is a 3-month window. So from cardiovascular events. So if they just had an MI, they're probably not. If they're 100 years old, they're probably not going to be eligible. So there's certain things, but I think everybody. So the danger, if the patient is truly interested and brings it up, but I think how many patients do we don't see the kind of the first time hypertensive patient. So somebody who comes in with who's 35 years old, has no cardiac problems, who's 135, who's 140 over 90, they're probably not going to walk into our doors and ask us what they should do with their hypertension. So we probably won't be at risk. So that's why the Facebook ad was important, because we knew we weren't going to get access. But patients who are on, I think the patients that we really want to focus on are the TRIO and the OnMed, which are patients that are, have some difficulty being controlled with, really anywhere from 1 to 3 medications. And, we receive referrals from many of you for that. So we thank you for that. But who are having side effects from medications. I think another thing is, if they have a GFR of, let's just say less than 40, they're probably not going to be a good candidate. If their hemoglobin A1C is greater than 9, then that's the exclusion criteria as well.
You mentioned about the renal denervation with the alcohol injection. Not being promoted, but is that anywhere near the horizon, or that's way down?
Well, no, I think that's being revived as well, and we've been approached by, so I think there's been some renewed interest in some of these other technologies. Some, like we were considering the creation of the AV fistula, which has now been put on hold. So for a variety of different reasons. So I think there's been some renewed enthusiasm in some of these other technologies. And so that device, obviously, I think Rob knows a lot about that study. And so I think, it's where you actually puncture through the renal arteries, and apparently it's very safe. And you infuse it with ethanol around the adventitia. So you're definitely going to deliver it and it's got a very good depth of denervation. So I think, I think some people are going to probably be involved in that trial, but I think these trials are going to define whether people have any interest in going that direction. So I think these 2 trials are far enough along and have established enough data that will say, if these trials fail, I think we're gonna, and the success and the failure of other devices will be based on this.
Question about the methodology of clinical trials. So I would imagine that the endpoint is usually blood pressure reduction. It's derived from the ambulatory blood pressure reduction. How do you decide when you show one number, or like a 6 millimeter reduction, you get multiple data points in a 24-hour period?
Right.
So what you've been using in clinical trials is it the maximum difference? Is it the average? Is it, how do you compare the sham versus the treatment arms when you get just one number out of multiple data points?
So I think we're collecting a lot of data, so they do have slightly different pre-specified endpoints in some of these trials. They don't all use the same one. And so I think it's based partly on their previous experiences. And so I think there's a lot being analyzed in these trials. And so I think it's primarily the average, is that kind of your question? Yeah. So I think, but they do analyze, and as the number of patients get greater, they will provide more analysis. And they're not looking just at blood pressure. They're looking at, because the sympathetic system is involved in a lot of different other disease pathologies. And so they're looking at an incidence of AFib, diabetes control, obstructive sleep apnea. So they're looking at how it affects, LDO, renin levels. And so they're looking at a lot of different variables, but I think as far as the blood pressure control, it's really, they're looking at, they have to use office blood pressure in some way because that's sort of been the gold standard for a long time.
It showed that it was a positive trial and significantly reduced the pressure, but was it based on when patients were taken off the medication or when they were?
Yeah, so I think the publications, the three main publications were, well, the two, sort of off medication trials were, so the patients were, they came in, they were demonstrated to be hypertensive, and they were taken off the medications. And so then they were randomized and they were asked to continue to hold their medications for two months in one trial, 3 months in another trial. And so because then you can eliminate the variable of what's happening with the medication. So I think with the HTN trial, there was people on too many medications, they were being manipulated. So this was the cleanest population to look at.
Yeah, I understand the idea, but let's say somebody a Norvas can get the, without it is 140/90, with it is 120/80, and then they take them off and then go from 140/90 to 120/80 after ablation. So is that the idea that you can achieve something with the ablation the same that you would achieve with the medication, or
Yes.
the reduction goes deeper? I don't understand what to compare. That's what I'm
Yeah, so we're so I think we're hoping that it hasn't, so I think we're looking to see whether that single variable has an effect. Obviously, I don't, based on our experiences, we'd be happy if it, looks like at this time it looks like it has an effect similar to at least some medications. And I think, the days of when we hope for a 30 millimeter decrease is probably not realistic anymore. But that's a good thing. You learn more from your failures and your successes. So that taught us how much we didn't know. And
years.
yeah, and I think you probably could do it like so very easily. So, I think because I think somebody told me, it's like, well, make sure there's no interventional radiologist in here. It's like, can anybody do it? It's like, yes, it's not difficult, but you kind of have to know my wife always says, she's a psychiatrist, and she says, I can do what you do, I just don't want to, so. Well, she actually says, I can do what you do better, but I just don't want to. So, and I think she can, but when somebody's coding, well, we'll see. But so I think it's not, and that's the danger of it, because once you have a procedure that's pretty easy, and maybe, I'm not saying TAVR is easy, but TAVR is getting to a point where you know, it's, you know, you can do it in many different settings. So that's a risk, is that, okay, if you have technology that's fairly easy to deploy, you know, is every doctor around the country going to start sticking these things? So the problem is that, you know, we truly believe that the person who does it should also have an understanding of the disease process and be willing to manage the problem, you know, because if somebody comes in with the blood pressure of 180 and you do a denervation and say, yep, see you later, you know, go home, and the doctor's not going to be very satisfied if the blood pressure is still 180, which, you know, a portion of patients, even with effective denervation, could be. So I think that's a risk. And I think if we're lucky enough to have it FDA approved, and this is hopeful in 2020 to 2021, there are probably going to be centers of excellence, which will probably be required. You have to have some experience with the devices to use it. So I mean, we certainly hope that we would be one of them. But I think as long as the technology gets refined and becomes more practical, I'm sure people will do it, because it is, I mean, it's not a hard procedure to do for interventional cardiologists or for a radiologist, or so. All right, thanks.